Good afternoon, everyone. Welcome to the STD clinical update on congenital syphilis for California pediatric providers. My name is Roslyn Klotzker, and I'm going to give it a few more moments just to let some people come on in. We'll be starting in a few moments. Again, for those who are just joining us, my name is Roz Klotzker, and this is the STD clinical update on congenital syphilis for California pediatric providers. Welcome. I'm going to give it just one more moment, and then we will get started. Okay, so welcome everybody once again to the California PTC STD clinical update on congenital syphilis for California pediatric providers. This is a presentation with two of our esteemed clinicians, Dr. Nael Mhaissen and Dr. Kelly Johnson. Dr. Mhaissen is a board certified pediatrician in both general pediatrics and pediatric infectious diseases. He is currently the medical director of infection prevention as well as infectious diseases at Valley Children's Healthcare in Madera, California, which serves multiple counties in the Central Valley in California. He has been involved in various clinical and educational projects that target the prevention and management of congenital syphilis, which is why California Prevention Training Center invited him to co-present today. His other clinical and research interests include valley fever, central line-associated infections, C. diff, as well as vascular health. So welcome, Dr. Mhaissen. In addition, we have Dr. Kelly Johnson. Dr. Johnson is a fellow in infectious diseases and an STI fellow here with us at the University of California, San Francisco, where she also completed her internal medicine residency and served as a chief fellow from 2019 to 2020. She is board certified in both internal medicine and infectious diseases and works as an HIV primary care provider at Zuckerberg San Francisco Hospital. And she provides sexual health services at San Francisco City Clinic. Her research interests include real-world implementation of HIV PrEP and the intersection between HIV and bacterial STIs, such as syphilis. And we are very lucky to have her here today as well. A little bit about the California Prevention Training Center, if this is your first time joining us. We are a multidisciplinary training and capacity building assistance, or CBA center. This is our logo, CAPTC, and we partner with the Center for Disease Control and Prevention on our activities. And we are part of the national network of STD clinical prevention training centers, which runs the STD Clinical Consultation Network, or STD-CCN. The NNPTC is comprised of 8 regions throughout the country. The California Prevention Training Center serves this region in the West, which includes California, Nevada, New Mexico, Arizona, and Hawaii, as well as Guam. And we partner across the country to provide training and capacity building assistance alongside other PTCs. If you have any STD clinical questions, you are welcome and encouraged to submit them to the STD-CCN. That is our online platform, which is staffed by subject matter experts. It can be about congenital syphilis or other STD questions. And you will get a response in 1 to 5 business days, either via phone or email, whichever you prefer. Here's our financial disclosure. And here's our CME disclosure. For CME requirements, you are required to have registered for this through the NNPTC, and you must watch the webinar completely and fully in this recording. So unfortunately, we can't give CME credit if you view the webinar as a recording, and attendance is noted as attendees sign on. In order to receive CME requirements, please complete the post-course evaluation survey, and you'll need to complete that by June 3rd. A link will be sent to you via email within 24 hours. So I'll say that one more time because we always get questions about it. You'll receive a link via email within 24 hours. You can check your spam box if you don't receive it, and that should be from Elizabeth Olson. Also, you'll receive the slides. The slides will be available in 5 business days. So I just wanted to let you know that as well. CME is provided from the University of Nevada, Reno, and it usually takes 6 to 8 weeks post-course survey evaluation. So once you complete the survey, then in 6 to 8 weeks, you'll receive notification. And as with the evaluation, please make sure to check your spam and junk folders if you don't receive it in your inbox. And this is the email address that would be sending you that CME notification. Okay, a couple more housekeeping things and then we'll get started. So your microphone and video will be turned off during the webinar. The chat will be turned off during the webinar. The Q&A will be turned on during the webinar. So if you have questions, please submit them to the Q&A, which is the double chat box, excuse me, the double speech bubbles. It says Q&A underneath and it is next to what says chat. So you can submit questions there and your questions will be answered either via myself through typing, or we'll save them at the end and answer them live. And here's a little bit about that. So this is just what the Q&A box looks like. And as I mentioned, you can click on that, enter there, and then attendees can submit questions up until the last 2 minutes of the Q&A section. And our presenters will answer attendee questions either directly in the chat window or live during the Q&A section. If you have any questions whatsoever, please contact our clinical program manager, Elizabeth Olson, and her email address is below, elizabeth.olson@ucsf.edu. And with that, I would like to hand it over to our first speaker, Dr. Nael Mhaissen.
Hello, everyone, and thank you for giving me the chance to present today. I'm just going to share my screen. All right, so I'm going to start by going over a case presentation about one of the patients that we've seen here at Valley Children's Healthcare. And just going right into it, we're going to assume that you're the pediatrician in the nursery and you get called about a new delivery. You are told over the phone that this is a male newborn delivered vaginally at 38 weeks of gestation, so full term. The mother is 40-year-old woman. She is a gravida 4, para 3, and now with this pregnancy, moving to 4. The baby is well appearing, normal physical exam, reassuring growth parameters. The baby's weight is on the 75th percentile for weight, length, and head circumference. This is not the picture of the baby, just a stock picture. The pregnancy is complicated, or was complicated, by limited prenatal care, gestational diabetes, methamphetamine use, and syphilis. So the mother's prenatal care labs showed that she was negative for her HIV screen, negative for a hepatitis B surface antigen, negative on the GC and chlamydia NAT, and several syphilis serology and treatment were as follows. So she was tested for it in the first trimester during this pregnancy, and she had the epidemiological antibody EIA, and that was non-reactive. She didn't have history of syphilis before. And this, again, testing in the first trimester was non-reactive. In the third trimester, this was repeated as per the CDC guidelines, and this time the treponema antibody EIA was reactive. So that was reflex to an RPR, and that was reactive as well with a titer of 1 to 64. She was treated with 1 dose of intramuscular penicillin G benzathine. She received that dose exactly 29 days prior to delivery. She had a repeat RPR at delivery, again, per the CDC guidelines, and the titer went down to 32. There was no clinical evidence of relapse or reinfection on the mother. The partner was also treated. So we'll move to the first question. So this is a poll question. A poll should show on your screen. Is the maternal treatment considered adequate? So again, this is a mother who was diagnosed with syphilis in the 3rd trimester, and she received 1 dose of IM penicillin 29 days prior to delivery. So is this adequate? Is it not adequate? Or are you not sure? Just allowing for some time for more answers. Let's go ahead and see the results. Okay, so majority answered no, although very closely, some of you answered yes, and then many were unsure, and that's okay. We'll talk about the discussion of these questions at the end of the presentation. Let's move on to the next question. What is the baby's diagnosis? Similarly, there should be a poll on your screen. Please go ahead and answer. And these diagnoses are the categories that are on the algorithm from the CDC and the American Academy of Pediatrics. Is this a proven or highly probable congenital syphilis? Is this possible congenital syphilis? Is this congenital syphilis less likely, congenital syphilis unlikely, or you're still unsure at this point, you need more information? We got around 140 answers the first time, so let's try to get to that same level, hopefully, with this question. Okay, let's see the results, please. So majority said possible congenital syphilis, and then a good percentage also answered unsure, need more information. It's probably a fair thing to answer at this point. Next question, how would you manage this infant? So again, based on the diagnosis that you chose, how would you manage this patient? Would you just check the RPR now? Or would you admit to the NICU for full evaluation, including lumbar puncture, eye exam, x-rays of the lung bones, CBC with differential, checking the liver enzymes, and treating with a 10-day course of IV penicillin? Or the third option, not checking anything, just giving 1 dose of penicillin, IM penicillin G, 50,000 units per kg per dose in a single dose. Or the last question, I'm not sure. This is a not very straightforward case. I'm going to consult ID and or the health department. Again, waiting for more answers. Can we see the results, please? So majority of you said you are going to admit this baby to the NICU, do the full evaluation and the full course of therapy. And then again, a good percentage still unsure. Again, very fair response. So what happened with the baby next? So the infant had his RPR checked and it was reactive. That titer was 1 to 16. The placental histopathology was normal, did not show any evidence of infection. The baby passed hearing screen in both ears. There was no other evaluation done, only the RPR. The baby was given the following diagnosis from the nursery: congenital syphilis less likely, assuming that the maternal treatment was adequate. And he received a single dose of benzathine penicillin G in a single dose and was discharged home. The baby was then seen for follow-up by the pediatrician who connected with the health department. The adequacy of the maternal treatment was questioned and more evaluation was done after consulting with the health department. The baby had a repeat RPR at 3 weeks of life that went down from 16 to 8. CBC with differential liver enzymes were checked and they were all within normal limits. The x-rays of the long bones, however, were read as abnormal. So the radiologist read it as periosteal thickening that could be a sign of residual periostitis caused by congenital syphilis. So with that abnormality, does that change your diagnosis? Again, another poll question. Does that change the diagnosis? Does that make it proven or highly probable? Is it still possible? Is it less likely? Is it unlikely? Or are you still unsure? You need more information. Can we see the results, please? So a tie between proven or highly probable or possible congenital syphilis. So what happened with the baby after? So the baby was directed to get admitted to the hospital after that. A lumbar puncture was performed. The CSF parameters were all within normal range for the patient's age, including the cell count, the glucose, protein. VDRL was also checked on the CSF, and that was then reactive. An eye exam was performed by a pediatric ophthalmologist, and that was reported as normal, no signs of congenital syphilis. Repeat long bone x-rays was done during the admission, and that was read as normal. There was maybe 2-week period between the first one and the first set of x-rays and the second ones. The baby was started on a 10-day course of IV penicillin. Unfortunately, the baby was taken home against medical advice at day 5 of admission. The family just showed up, and they did not believe the family that the treatment was necessary, and they took the baby home against medical advice. And the question is, what would you do at that stage? So would you say, you know what, 5 days is enough? Further antibiotic treatment is unnecessary, would only follow the RPR on the infant every 2 to 3 months until they become non-reactive? Or would you try to bring the baby back by contacting social worker, CPS, to give 5 more days of penicillin? Or would you bring the baby back and restart the entire course, give 10 days? Or are you unsure? So again, call it quits, try to finish 5 more days, restart the entire course, or, you know, I don't know. All right, let's take a look at the results. So it seems like majority said they would bring the baby back to the hospital to give 5 more days. Some also answered that they would bring the baby back, but restart the entire course. And again, very fair response to say unsure at this stage. So I'm gonna end my case here. I know that we have a lot of things to discuss and talk about, but I'll leave that at the end after we hear that presentation from Dr. Johnson. So we'll come back and talk about the case again, about the questions and the answers and the rationale behind the management of this baby. Dr. Johnson.
Great, thank you, Dr. Mhaissen, for that great case introduction. I'm going to go ahead and share my screen and take it from here. Okay, great. So I'll apologize in advance. My voice I'm getting over a cold, so I'll do my best. And this is all being transcribed, so look at the bottom if you're not sure, if you can't hear me very well. I'll be leaning in so you can hear me as best as possible. In any case, we'll now be taking a step back from the individual case to talk more globally about the diagnosis and management of congenital syphilis with a focus on pediatric providers. I have no disclosures to report. In terms of our objectives for this part of the talk, I'll be discussing how to describe California's congenital syphilis epidemiology. I'll be referring to congenital syphilis as CS throughout this talk elsewhere. We'll be learning to recognize the clinical manifestations of CS, to discuss CS diagnosis, evaluation, and management, and to learn to report all laboratory confirmed and clinically suspected cases of CS to public health. I'll begin with a bit of information regarding CS epidemiology. First, on the national scale, as you may already be aware, the CDC recently released its 2019 STD surveillance report, noting that STDs increased in our country for the 6th straight year, reaching a new all-time high. Concerningly, there were nearly 1,900 cases of syphilis among newborns, representing an increase of 279% since 2015. To give some historical perspective on this, starting around the year 2000, both the US and California began seeing an increase of syphilis cases among men. Most of these cases were among men who have sex with men, of whom about half were also living with HIV. While these trends have continued, however, there's also been an increase in early syphilis cases among females that we've seen since 2012. More specifically, as shown on the graphs in this slide, California has experienced a steep increase in syphilis among females and infants, which respectively increased by 550 and 900% between 2012 and 2018. As of 2018, California contributed about a quarter of the total congenital syphilis cases that we see nationally. These numbers are alarming at face value, and even more so when you consider that CS is entirely preventable. It can be avoided with testing and treatment during pregnancy. Speaking a bit more to the epidemiology of CS in our state, this is a map of California showing the congenital syphilis cases by county in 2018. The darker the maroon, the higher the case count. The highest morbidity counties in terms of cases in our state are in Central and Southern California. In 2018, 10 out of 58 counties had 10 or more cases of congenital syphilis. Many counties are now seeing their congenital syphilis cases increase, and some are experiencing their first CS cases in years, indicating the cases are continuing to spread. Diving even a bit deeper into California's CS data, again as of 2018, most pregnant women with syphilis were between the ages of 20 and 34, and as this graph shows, most cases of congenital syphilis in our state were born to Latina mothers. However, as we see here, the highest rate of syphilis among pregnant women in 2018 in California was actually among Black mothers, where the rate was 4 times the rate of Hispanic and white mothers, obviously a concerning health disparity. This next slide shows a list of maternal risk factors reported by mothers of CS infants in California. The most prevalent risk factor, which we also saw in our case, is limited or no prenatal care. In 2018, this characterized 57% of CS cases, followed by methamphetamine use in over half of the mothers. Recent incarceration in the past year represented more than a quarter of cases, with homelessness as a factor in 18% of cases. So many of these women are diagnosed with syphilis in the context of complex social determinants of health, including poverty and disparities in access to care, which may drive many of the reported risk factors. This slide here intends to drive home this point about the importance of such social determinants of health on CS. The map on the left shows CS rates by county, while the map on the right shows the percent of the population living in poverty by county. As you can see, many of the counties with the highest CS rates are the exact same counties with the highest percent of their population living in poverty. Finally, as I alluded to previously, CS deaths are largely preventable if mothers are successfully diagnosed and treated either before becoming pregnant or earlier in their pregnancy. Mathematical modeling studies have in fact shown that about 70% of CS stillbirths are likely avoidable if syphilis treatment is given by 21 weeks of gestation. Of course, for myriad reasons, that may not always be possible. And the rest of today's talk on my part will focus on the diagnosis and management of infants born with confirmed or suspected CS. We'll begin the next section of this talk by discussing the clinical manifestations of CS in infants. To take a step back and provide a brief overview, Syphilis is caused by Treponema pallidum, a spirochete bacterium. Its incubation period is typically 3 to 4 weeks with a full range of 10 to 90 days. It causes systemic infection with episodes of active disease interrupted by periods of latent or asymptomatic infection. In general, transmission most commonly occurs via direct contact to infectious lesions, but can also take place via the placenta in maternal to child cases. Of note, transplacental transmission usually occurs in symptomatic maternal syphilis, also known as primary or secondary syphilis, when maternal serology such as RPR and VDRL have titers that are typically on the higher side. And this is opposed to latent disease. Most infants with CS are actually asymptomatic at birth, somewhere in the range of 60 to 90% of these infants actually, depending on the study. However, early manifestations occurring shortly thereafter and up to 2 years can include the ones shown on this slide, things such as hepatosplenomegaly, snuffles, which are copious nasal secretions, pneumonia alba, which is a quote unquote white pneumonia, where spirochetes in pulmonary tissue cause the lung to become firm and pale with inflammatory cells and fibrosis in the alveolar septa. Infants may also have osteochondritis, pseudoparalysis, a type of paralysis usually of the upper limbs, and they may also have edema, rash, lymphadenopathy, and or blood cell count abnormalities such as hemolytic anemia or thrombocytopenia. Late manifestations of CS occur at age 2 or older and include findings you see on this slide. These are things like interstitial keratitis, eighth cranial nerve deafness, something called Hutchinson's teeth, which are these peg-shaped notched central incisors that you see in the top middle right image on this slide. They may also have mulberry molars, which are defective permanent molars with multiple rounded rudimentary enamel cusps, as well as frontal bossing, saddle nose deformity, perioral fissures, or something called Clutton joints, a symmetric painless swelling of the knees. I mentioned that infants infected with syphilis may be asymptomatic, but why is this the case? Some possible contributing factors include the virulence of T. pallidum, which may be modulated by maternal immune responses, combined with the child's own genetic makeup, as well as the fact that T. pallidum can vegetate until appropriate biological and physical conditions promote virulence and allow pathogenicity. For all of these reasons, treatment is important, even late in pregnancy and even in the postpartum period when infants may appear normal. In the second half of my part of this talk, we'll now move into the main event, which is the diagnosis, evaluation, and management of congenital syphilis, as you may see in your patients. I'll acknowledge first that the diagnosis of congenital syphilis can be difficult, as many infants born to women with syphilis are asymptomatic, like we talked about, and both maternal and non-treponemal antibodies can be transferred from the placenta to the fetus. So treatment decisions must be based on several other factors, many of which the prenatal care provider will need to communicate with the pediatrician to best care for your patient. These factors include identification of syphilis in the mother, confirmation of the adequacy or inadequacy of maternal treatment for syphilis, the presence of clinical, laboratory, and or radiographic evidence of neonatal syphilis in the baby, and finally, a comparison of maternal and neonatal serologic titers at the time of delivery. Because treatment decisions in CS may ultimately often hinge on understanding maternal diagnosis and treatment, I'd like to take a moment to discuss syphilis diagnostics in adult patients. Unfortunately, detection of T. pallidum from clinical specimens can only be done by dark field microscopy or by PCR, neither of which tests are widely available. So syphilis diagnosis in adults relies on serologic testing, with tests that fall into 2 major categories, treponemal and non-treponemal. You need both types of serologic tests to confirm a syphilis diagnosis in adults. So on the left-hand side of this slide, you'll see non-treponemal tests. Examples of these tests are the RPR and the VDRL. These detect antibodies against a substance called cardiolipin. And these, importantly, are qualitative tests, allowing for assessment of disease burden, treatment adequacy, and reinfection. So if you see a fourfold increase in an RPR titer, such as from 1 to 8 to 1 to 32, that would be consistent with a new syphilis infection. Non-treponemal tests, however, are nonspecific, meaning they can be positive in patients with other conditions. This is why adults need a treponemal test to confirm their syphilis diagnosis. When you're talking about maternal to child transmission, you want to perform the same non-treponemal test on the infant that was performed on the mother. And both the CDC and the AAP recommend using infant serum rather than the umbilical cord blood due to risk of false positives from contamination with maternal blood in the umbilical cord blood sample. So moving over to the right-hand side of this slide, you'll see examples of treponemal tests. These include things like the TPPA, the FTA antibodies, and immunoassays like the EIA and the CIA. These tests detect antibodies specific to T. pallidum. The antibodies usually stay positive for life after initial infection. So these aren't quantitative, and they can't be used to assess for reinfection or to evaluate response to treatment. Importantly, maternal TPPA can also stay positive in infant serum for up to 15 months. And what that means is, in most situations, you don't use treponemal tests for infant screening or diagnosis. You rely on the non-treponemal tests that we previously discussed. So with all that said, we come to the first of my audience, and actually the only of my audience response questions. So the question is, true or false? Traditional syphilis screening algorithm begins with a treponemal test, and the reverse screening algorithm begins with a non-treponemal test. So you can pick either true or false, or I don't know. And I'll give you a minute to think about that. Okay, can we go ahead and see the answers, please? Okay, so good split here. 51% of people, about half, said that this is false, but over a third, 34%, said that this is true. And then, fair enough, another 15% said they don't know. I will go ahead and show you the answer on the next slide. So those of you who picked false were correct. I was being a little bit tricky here. The traditional screening algorithm in adults is the one that begins with a non-treponemal test, again, like an RPR or a VDRL, while the reverse screening algorithm begins with a treponemal test, usually an EIA or a CIA. Just to review this concept, because it does become relevant in CS cases, there are two different ways you can screen and test for syphilis in adults. Again, one is via the traditional screening algorithm, and one is via the reverse screening algorithm. And the latter algorithm is being used more frequently. We'll go through each of these in turn as a quick general overview for your understanding. First, in the traditional screening algorithm, you start with a non-treponemal test, like an RPR. If the RPR is negative, you're done, testing stops. But if the RPR is positive, the test should reflex to a treponemal test, such as the TPPA. If the TPPA is negative, syphilis is unlikely, and the positive RPR is usually considered a false positive. Though serologic testing is repeated in 2 to 4 weeks in pregnant women to confirm these results. On the other side of that coin, though, if the TPPA is positive, this indicates that the patient has either past or present syphilis. The patient's clinical and testing history can then be used to determine whether it's an old treated infection, a past infection that has been inadequately treated, or a new infection. Pertinent information used to make these determinations in adults includes any symptoms of primary or secondary syphilis, any prior syphilis diagnosis and treatment history, as well as RPR titers. which again, you want to see a fourfold change from prior to represent a clinically significant result, as we've discussed. For the reverse screening algorithm, which is shown on this slide, you start with a treponemal test. Again, that's usually an EIA or a CIA. If that's negative, you're done, and the patient is not diagnosed with syphilis. If the EIA or CIA is positive, a standard RPR is performed next. If that RPR is positive, the patient has past or present syphilis, just as with the traditional screening algorithm. However, if the RPR is negative, a second treponemal test, usually a TPPA, is done next. If the TPPA is positive, past or present syphilis is confirmed. Management at that point then depends again on the clinical scenario. First, if the adult patient has a known history of treated syphilis, so they've been treated, they have no new exposures that they report, then you think the positive EIA or CIA and TPPA probably represent prior exposure and the patient doesn't need further treatment. On the other hand, patients without a known history of treated syphilis, but with a positive EIA, CIA, and TPPA should be offered treatment. Unless the patient's history or results of a physical examination suggest a recent infection, previously untreated patients who are asymptomatic are usually treated for late syphilis. And again, I know we're spending some time on adults here, but this slide shows the treatment algorithm for syphilis in adults, including pregnant women. Early syphilis, comprised of primary, secondary, and early latent syphilis, which again is asymptomatic syphilis within 1 year of diagnosis. These patients only require 1 dose of intramuscular benzathine penicillin. Syphilis of late or unknown duration, however, requires 3 doses of intramuscular benzathine penicillin given at weekly intervals. In pregnant women with late syphilis, if intervals are beyond 6 to 8 days, the full 3-dose course of penicillin therapy should be restarted. And there are no alternatives to penicillin, unfortunately, for syphilis treatment in pregnancy. Note that inadequate treatment for pregnant women consists of any non-penicillin therapy or penicillin given less than 30 days before delivery of their baby. That is relevant to the case that we heard at the beginning of this talk. So how do you understand maternal syphilis serologies and treatment history, especially if you're a pediatrician? Just so you know, there are several resources available to help you understand whether a mother received adequate treatment for a syphilis diagnosis. You can consider contacting your local health department for assistance reviewing prior maternal syphilis tests and confirming whether adequate treatment was received. Or if you're looking for clinical consultation or help interpreting maternal syphilis test results, you can consider the STD CCN Warm Line, which is a website available at www.stdccn.org. Okay, now we're going to turn back to infants. When it comes to the evaluation and management of infants born to women with syphilis during pregnancy, there are several scenarios that can be used to help guide clinical management. This algorithm shown on this slide is included as a resource for you before we dive into the details of various CS management scenarios. You can always come back to this algorithm as a quick reference to help you understand which scenario might best fit your patient. Note that for all patients born to women with syphilis during pregnancy, the algorithm starts with the infants and mothers both having a serum RPR or VDRL drawn at the time of delivery. The algorithm then proceeds down the different pathways for infant evaluation and treatment, depending on which scenario is at play. And we'll go through each of them now. In scenario 1, these infants are those in the category of proven or highly probable congenital syphilis. These infants have either an abnormal physical exam consistent with CS or a serum RPR or VDRL titer that is 4-fold or more higher than the maternal titer at the time of delivery, or a positive dark field or PCR of infant lesions, body fluids, or the placenta. In these cases, a full workup, which I'll define, as well as 10 days of treatment with IV penicillin is recommended. To speak a bit more about the laboratory criteria for the diagnosis of CS, the laboratory criteria in scenario 1 infants involves the demonstration of T. pallidum by dark field microscopy, PCR, or immunohistochemistry or special stains of any lesions, body fluids, and/or the placenta. Regarding placental pathology, the placenta of neonates with congenital syphilis is often large, thick, and pale. The umbilical cord is edematous and may resemble a barber's pole with spiral stripes of red and light blue discoloration that alternate with streaks of chalky white. It may be significantly inflamed with an abscess-like necrosis within Wharton jelly centered around the umbilical vessels themselves. Importantly, in at least one study, use of placental histopathology increased detection of syphilis from 67 to 89% in live-born infants and from 91 to 97% in stillborns. So in terms of infant evaluation, in patients meeting criteria for scenario 1, again, that means they have physical exam findings of CS, an RPR that is 4-fold higher than mom's at delivery, or PCR or dark field positivity from a body fluid lesion or the placenta. In these infants, a full evaluation, including each of the studies on this slide, is recommended. This includes a careful physical exam, a CSF analysis for VDRL, cell count, and protein, a CBC with differential, as well as other tests as indicated, including x-rays of long bones and chest, LFTs, an ophthalmologic exam, and possibly neuroimaging or a type of hearing test to assess the auditory brainstem response. Going into more detail regarding the full evaluation of CS, especially since this was relevant to our case at the beginning of this talk, on this slide, you'll see an example of CS X-ray findings such as periostitis and osteochondritis. Note that the CSF evaluation in neonates and infants can be imprecise. In at least one study of 76 babies with CS who had definite evidence of spirochetes in their CSF, VDRL was only 53% sensitive. White blood cell count was even less sensitive at 38%. And the sensitivity of elevated protein was similar to that of the VDRL. Protein was the least specific. Given these test characteristics, it's important to realize that CSF protein and white blood cell count can be elevated in many conditions other than syphilis. So you have to consider the CSF evaluation in the larger clinical context of your patients. This is also a table that's just reproduced from UpToDate, and I've included it here not for you to memorize, but just as a reminder that the parameters of normal for CSF white blood cell count, protein, and glucose actually vary depending on the age of the neonate. This is just another caveat to remember when you're interpreting CSF values in your patients. Moving on now to scenario 2. Scenario 2 CS infants are those that fall into the category of possible congenital syphilis. These infants have a normal physical exam and a non-treponemal titer that's less than or equal to 4-fold the maternal titer, but there are concerns regarding the mother's syphilis treatment. The mother may have been untreated, inadequately treated, treated with a non-penicillin regimen, or have started treatment less than 4 weeks or 30 days prior to delivery. For the infants in these cases, complete workup is necessary if 10 days of penicillin treatment is not planned, but may be deferred if the 10 days of treatment with aqueous IV penicillin is given. If the complete evaluation is done and is normal, and you have certain infant follow-up, a single dose of IM benzathine penicillin at 50,000 units per kilogram may be given instead. In scenario 3 infants, congenital syphilis is considered less likely. These infants have a normal physical exam, a non-treponemal titer that's less than or equal to 4-fold maternal titer, and unlike with scenario 2, their mothers were adequately treated without evidence of reinfection. No infant evaluation or workup is needed, but a single dose of IM benzathine penicillin, again at 50,000 units per kilogram, is again recommended. Finally, in scenario 4, congenital syphilis is considered unlikely. Once again, these infants have a normal physical exam, a non-treponadal titer that's less than or equal to fourfold the maternal titer, and their mothers were adequately treated. In these infants, maternal non-treponadal titers, like the RPR, were low and stable, such as less than 1 to 2 or less than 1 to 4, before and during pregnancy, as well as at delivery. For the infants in these cases, no evaluation is needed and treatment is not required, though some experts would still, once again, give that single dose of IM penicillin, particularly if follow-up is uncertain. So this slide summarizes the treatment regimens for CS. Remember that full treatment for scenario 1 and some scenario 2 babies typically consists of IV aqueous crystalline penicillin, with the dosing shown on this slide, for a total of 10 days. Remember that a single dose of IM penicillin can be used instead in scenario 2 infants with possible CS but a normal workup, or in scenario 3 or 4 infants when congenital syphilis is considered less likely or unlikely. So, after you have diagnosed congenital syphilis and made your treatment decision, how do you follow these infants? Whether treatment is given or not, you should obtain an RPR every 2 to 3 months until the test becomes non-reactive. Non-treponadal titers should decline by 3 months and be non-reactive by 6 months if the infant was adequately treated or if they never had a syphilis infection. You should reevaluate and treat again, or for the first time, if the RPR titer persists at 6 to 12 months. For infants with an initial abnormal CSF, the 2015 STD treatment guidelines recommend repeating an LP at 6 months. I need to point out, however, that this recommendation is expected to change in the upcoming 2021 STI treatment guidelines, such that infants whose RPR becomes non-reactive at 6 months will no longer require that repeat CSF evaluation. So, what do you do if a potential CS case was not diagnosed at birth but found later, say when the child is a month or more old? How do you evaluate and treat infants and children older than 1 month? Well, you should again start your evaluation with an RPR. If the RPR is positive, you should proceed with CSF analysis with your CBC and differential, with an HIV screen, and with other tests such as long bone x-rays, chest x-ray, LFTs, possibly an abdominal ultrasound as indicated. Treatment in these cases is, again, aqueous penicillin, given now at 200 to 300,000 units per kilogram per day, IV, in divided doses for a total of 10 days. If all the tests are done and normal, you could instead consider IM benzathine penicillin at 50,000 units per kilogram intramuscularly times 3 in weekly intervals. Just to highlight this again, because I know I went through a lot of information, just remember that there's a resource available to help you determine which scenario best describes your patient and to help guide your workup and treatment decisions. Finally, in the last section of this part of the talk, we'll discuss the importance of reporting CS cases to public health. First, please know that your health department is here to help. Know that your local health department can provide information on maternal syphilis history, including past titers and treatment, if you're trying to determine whether a patient's mom was adequately treated or not. Your local health department can also help you find patients who are lost to follow-up. They can notify partners anonymously in order to get them tested and treated, and they can help provide access to treatment for syphilis if that's needed. You should also know that under Title 17 of the California Code of Regulations, suspected or confirmed cases of syphilis are required to be reported to the local health department based off the patient's residence within 1 working day. This information can be sent by fax, telephone, or mail, or via online provider reporting portal. For patients who could become pregnant, a recent update is that pregnancy status, if known, is also now required to be reported. This slide shows an example of the reporting form, which is called a CMR, or Confidential Morbidity Report. Remember that if you are treating a baby with CS, reporting the case may result in the mother ultimately getting treated. And that helps us achieve the goal of preventing further CS cases if they were to become pregnant again in the future. Finally, in an effort to combat rising cases of CS in California, I want to share that our state has recently expanded its syphilis screening guidelines, as shown on this slide. I won't review all of them, but these guidelines now include screening for all pregnant patients at least twice during pregnancy, as well as screening pregnant women again at delivery, unless they're considered low risk and they have a documented negative syphilis screen in the 3rd trimester. So overall, California is increasing efforts to make sure that as many syphilis cases in women are and in the population are diagnosed and treated properly with the goal of preventing CS from occurring. Here's other resources that are available to you. You can check out std.ca.gov for more information on congenital syphilis from the California Department of Public Health. And with that, I will turn it back over to Dr. Mhaissen to complete our case and to wrap up this webinar. Thank you all so much for your attention and for letting me give this talk.
Thank you. Let me go ahead and share my screen. I'm going to go through the case again and look at the answer and the question one more time, allow you guys to answer them now after you've heard this excellent presentation from Dr. Johnson. So just a quick reminder, we're dealing with a full-term male newborn. Mother was diagnosed with syphilis during pregnancy. She had a negative test early on in the 1st trimester, but had a reactive EIA on the 3rd trimester. So she went through the reverse algorithm for testing, and then that was confirmed with an RPR with a titer of 64, and she was treated with 1 dose of IM penicillin 29 days prior to delivery, so not 30 days like the CDC recommends, and only 1 dose, so there wasn't a 2nd dose given a week after, like many experts would recommend if you're treating early syphilis in a pregnant mother, which makes this therapy again questionable. She had repeat, I mean the adequacy of it. The repeat RPR at delivery was down to 32, and there was no clinical evidence of relapse or reinfection. Partner was also treated. So we'll go to the question again. What do you think of the treatment, knowing what we know? Is this adequate? Is this inadequate? Are you unsure? Again, she got 1 dose. Well, she was diagnosed with early syphilis. She got 1 dose 29 days prior to delivery, no 2nd dose after. I see more answers coming in. Let's look at the result, please. So a majority of you said that no, the treatment is inadequate. And again, based on the CDC guidelines, I agree. Next question. Just go ahead and answer that. So based on that, what is your baby's diagnosis? So you have a inadequately treated mother, and you have a baby that's well appearing on exam. That's all you know. So is this proven or highly probable congenital syphilis? Is this possible congenital syphilis? Is this less likely or unlikely? Or you're still unsure, you still need more information before you make that diagnosis? Again, so far you only have mother's treatment history, and you have normal physical exam on the baby. Let's look at the answers, please. So a majority of you answered possible congenital syphilis, and then some of you said disproven or highly probable. And the answer is it's probably one of these two. So it's at least possible, maybe proven or highly probable, but if you want to go by the correct answer here, it is unsure. We still need more information. We need at least the RPR on the baby or the full evaluation to give a final diagnosis. At this point, this is either possible or proven or highly probable. And when we go to the next slide, this just tells you that the baby had the RPR checked and it was less than what the mother's RPR was. So oh, sorry, this is the question. Apologies. So let's answer this again. How would you manage this infant? Again, you think that this is either possible or highly probable. So what do? Do you check the RPR only? Do you admit for full evaluation and full treatment? Do you give the penicillin G only the 1 IM dose, or are you still unsure? You talk to ID in the health department. Apologies for the mix-up. I thought this was a different slide. And let's look at the answers, please. So that is the correct answer. You need the full evaluation. If the mother's treatment is considered inadequate, then you need the full evaluation and the full treatment for the baby. And then the course, again, the baby did not have the full evaluation, only had the RPR checked early on. The titer was 1 to 16. They did look at the placenta. The histopathology was normal. The hearing screen was normal. No other evaluation. The baby was given a diagnosis of congenital syphilis less likely. At the time, the maternal treatment was considered adequate. And then the baby just received a single dose of benzathine, penicillin G, and sent home. But then later on, when the baby presented to the pediatrician, when the case was also reviewed by the health department, the adequacy of the maternal treatment was questioned, and then more evaluation was done on the baby. The repeat RPR on the baby was still trending down, went down to 8. However, the X-ray at this time was abnormal. So you have abnormality on an X-ray. What does that make the diagnosis? So let's look at that question now. What is the diagnosis for this baby now that you have abnormal X-rays? Let's look at the results, please. So with that, that actually elevates the diagnosis to proven or highly probable congenital syphilis. Once you have that abnormality, regardless of the mother's mother's treatment history, having such abnormality on physical exam or your evaluation elevates it to highly probable or proven congenital syphilis. So based on that, the baby was brought to the hospital for full evaluation, full treatment. There was that confusion because when the repeat X-rays were done, were read normal. Yes, there was a period of time. Maybe some of these changes resolved, or maybe the early changes were normal variant. Again, it's hard to tell. But this is a situation where you do not want to take risk. You heard from Dr. Johnson's presentation that many times the baby may look normal, the evaluation may look reassuring, but then you may deal with some long-term consequences. So congenital syphilis is one of these conditions where you always want to err on the side of caution. So the last question then, that unfortunately this family did not continue with the treatment. They did take the baby home before ending the 10-day course. So what do you do in such a situation? Again, if the course, the 10-day course that you planned was interrupted, how would you manage this? Can you please load that poll question? Yes, this one. So what do you do when the treatment course is interrupted? And I do recognize that I'm asking this question in an unfair way because I didn't tell you how long the interruption was for. But I think that's one of the things I wanted to mention in this question, or try to highlight that important point about the therapy. Can we see the answers, please? So many of you answered contact social work, CPS, bring the infant back and restart the full 10-day course of therapy. And that practically, that's probably the correct answer. Now, the the issue is if you have more than 24 hours of interruption, so a 1 full day of treatment was missed, then you have to restart the entire day course. Now, if you're lucky enough and you got social worker and CPS and everyone, you got the baby back for the 24-hour mark, so without missing 1 full day, then you may continue with the 5 days. So again, for practical reasons, the correct answer is 3. Which is when you bring back the baby back, which what you should attempt to do, you have to restart the full 10-day course if it got you more than 24 hours to do so. And that was the last question I had. I will bring this back to Dr. Plotzker now for wrap up and a Q&A session.
Hello. All right, so let's go to our Q&A. All right, so one thing, this is actually kind of an interesting question, and I wanted to put this to Dr. Mhaissen, who is our pediatrician on the line. There's a question, how do you screen for congenital ocular syphilis? So, Dr. Mhaissen, what are your thoughts about congenital ocular syphilis?
Right. So there are different manifestations from ocular standpoint that congenital syphilis could have. Some babies may have glaucoma, some may have cataracts, they may have uveitis, chorioretinitis, or just retinitis alone. Some also may have loss of the hair of the eyebrows. So some eyelid abnormality. So the way we do this, the way we screen for congenital ocular syphilis is we consult our pediatric ophthalmologist. And I know in many local hospitals here or clinics that you may not have that option readily available. You can refer the baby out even after discharge. So if you don't have a pediatric ophthalmologist that can come into the nursery and check the baby, at least on an outpatient setting, make sure that such referral is made and is being followed up on. Sometimes these things can be progressive. One thing about the treatment of congenital syphilis, it does prevent many of the complications of congenital syphilis, but not all of them. So ocular manifestations, unfortunately, cannot all be prevented even with the adequate treatment of the baby. So always make sure that eye exam is completed. And again, the way they do that is by routine exam by a pediatric ophthalmologist, dilated eye exam endoscopy.
Yeah, and just to clarify for the audience, I think that when you are evaluating an infant, you basically definitely want to do a thorough physical exam, a thorough, if there's a possibility of scenario 1 or scenario 2 infant, then you want to get your CSF and look at your blood work and anything else that's indicated based on your exam. But you do not, and Mhaissen, Dr. Mhaissen, correct me if I'm wrong, you do not need to have an ophthalmologist evaluate every single infant who's been exposed to syphilis in utero. Is that correct?
So if you follow the guidelines from the AAP, the American Academy of Pediatrics, and the CDC, they say as indicated.
Exactly.
There's one thing that you do on every newborn baby, part of the exam routine, which is checking the red reflex. Right. But that would only show you abnormality, if cataract is one of the presentations. Personally, if you ask me, my preference is to involve pediatric ophthalmology in these two scenarios where you have possible syphilis or proven or highly probable. In these cases that are important, and many of the here at Valor Children's with the baby had chorioretinitis, unfortunately became blind in one eye. And again, this isn't something I can tell by my routine newborn exam. This required a pediatric ophthalmologist. So my personal preference is to refer to pediatric ophthalmologist for these cases, again, if possible or proven or highly probable.
Okay. All right, next question. And also this is a nice time to just note that with congenital syphilis, and the reason that we brought a pediatric infectious disease specialist on this call is that, I think that the CDC offers very I think that their guidance is very clear, but with congenital syphilis, it is so nuanced and requires a lot of experience, like what Dr. Mhaissen has, as well as clinical judgment. And so, CDPH and the California Prevention Training Center and all of the guidance that we put forth endorses what CDC recommends. But if there is question or concern, and there's a reason you might want to do additional testing in addition to what's recommended, then that is fine. That these guidelines are things that are not things where you necessarily have to stop if you have additional concern. And that's why it says things like additional tests as indicated. And that's where clinical judgment really comes in. Okay, so, all right, another question. So this was put out that says, and this looks like it's to Dr. Mhaissen as well, why did the parents discharge the baby from Valley Children's Hospital? Was it an issue of the type of treatment the baby was getting or the cost of the treatment? And so now we're getting into the logistics of taking care of these babies.
So, not to get into the details of this case, but I just have to show you, it wasn't the cost. There was just some confusion, some disagreement from the family standpoint, whether the treatment was necessary or not. Again, it's not when you have a well-appearing newborn and you're telling the family, oh, no, you have to stay in the hospital and undergo this test and that test. It's not always an easy thing for them to follow. The reason I wanted to bring that point is just to drive that point home of, if you have interruption of the course of therapy, many times you have to restart the entire course. But again, I don't think it's fair to go into the details of this case and from a social standpoint.
Okay, great. So there's two questions. I can just answer these quickly. I started to type, but I'm a faster talker than typer. The first is just to confirm, it is recommended for pregnant women to get 2 doses of BIC 2.4 million units, even if they are diagnosed as an early case of syphilis. So the answer to that is no, you actually only need to give 1. Some people will give an extra dose, and the thinking behind that is that the pharmacokinetics for benzathine penicillin G aren't as well mapped out for pregnant patients as they are for non-pregnant patients. The vast majority of the evidence supports that the penicillin will last for the duration that you need it to be therapeutic during pregnancy. And so CDC recommends 1 dose is fine in early syphilis. So if someone hasn't gotten a second dose, that shouldn't give you a concern that they weren't adequately treated. And also it can take time for the titers to decline 4-fold. So if they haven't declined 4-fold by the time of delivery, that also doesn't mean that they weren't adequately treated with the single dose. So that's one. And then the next one says, and this one's a funny one. So is it 4 weeks? The algorithm says 4 weeks or 30 days. And, this used to come up sometimes for people who were treated 29 days before delivery. So the CDC guidance says 4 weeks, which is 28 days. Elsewhere in the guidance, it used to say 30 days. And I think that in the forthcoming guidance, which is the 2021 CDC STD treatment guidelines, which is coming out this year, I think that they clarify it. And I'm pretty sure they're landing on 4 weeks. So I would just go with 4 weeks. Dr. Mhaissen, Dr. Johnson, I'm not sure if you have any additional thoughts on this.
No, it's not that I have additional thoughts, but it is very important a point for this case, because this patient was 29 days before delivery, got her treatment, right? The mother. In this case, the baby ended up having an abnormality by X-ray that made them, a probable or highly proven case. So I don't know. I'd be curious to hear what you think, Dr. Mhaissen.
Again, with congenital syphilis cases, I'm someone who tend to err on the side of caution. Again, we might debate and disagree. Is this adequate? Is this not adequate? But I think whenever we have a question like this, and you have potentially significant complications at stake for the baby, I think the full evaluation would have been indicated, even if you want to at least to augment your decision. Are you going to do a full 10-day course or just one dose?
Yeah, and I think that that's a good point too. And this circles back to using your clinical judgment, that all guidelines are only that, they're guidelines. And so, you know, I have received consultation from people who say, you know, this kid was born to someone who was adequately treated, but their titers were incredibly high. So even though this is someone who meets criteria as a scenario 3 infant, because of the very, very high titers during pregnancy, that makes me worried about vertical transmission. And so I'm going to go ahead and do a CSF and do long bone x-rays on this infant because of my clinical judgment, right? So, so it's a very important point to remember. You are encouraged to use your clinical judgment when managing these cases. And with that, there's a question that's pretty interesting. How often are clinical findings positive on long bone x-rays? And should the long bone x-rays be done in the hospital prior to discharge if CS is probable? So Dr. Mhaissen, what do you think about that?
Most of the congenital syphilis manifestations are rare. The one that I see the most is really the changes on the x-rays. So it's something that we routinely do on every baby that comes to Valley Children's here. Also, every time I'm consulted on a case from the local hospitals and clinics around here, I do recommend that. It's a relatively simple thing to do, and it may give you the diagnosis.
Great. Okay. All right. We have a few more questions in a few more minutes. So this one came in from a colleague in Northern California. Hi, Kathy. This is from Kathy Kelly. If you have a probable CS case, but the infant's RPR was negative, does that change your follow-up testing? In other words, does the infant still need repeat RPR in 2 to 3 months? So I'll let Dr. Johnson take this one if she's open to that.
You can correct me if I'm wrong. As you guys can tell, I'm an adult provider, and the reason I gave this talk is because there's so much about treating the mother that ties into management of CS. So that's really my strong suit. But my inclination would be, if you're treating a baby for CS, and the incubation period we know is up to 90 days, that I'd still repeat an RPR in 2 or 3 months.
Yep, exactly. Yeah, so there's a possibility that there could be incubating syphilis, and that's why you do another RPR in 2 to 3 months to confirm. All right, so let's see. All right, I have a few questions related to the case itself. Dr. Mhaissen, are you ready? Okay, first is reflecting back on this case, what could the Valley Children's Hospital clinical team do differently to avoid a family discharging a baby before the baby is fully treated? And I know that's a loaded question.
It is. Again, there's only so much you can do. There's, providing counseling, providing resources for transportation if that's the issue, trying to work with some resources for caring for the other children while this baby is in the hospital with the family. Again, there are several things, and I do not want to go into the details of this case. I don't think that's an appropriate thing to do in terms of the complex social situation, but that just speaks to complexity of these cases. Unfortunately, many times the caregivers for babies with congenital syphilis are not necessarily the most your families that will follow up with clinic visits, with studies as recommended. They're not the ones that are necessarily going to take your advice right away and do everything that they're supposed to do. There are many times where they come from complex social background, and you have to work a lot with them in terms of support and trying your best to do the best for the baby. But then again, what you can do, in this case, we did work with CPS, with the health department, with social work, and we still are actually trying to give this baby the therapy that we believe he needs.
Thank you so much. And on that really good note, unfortunately, we're at time. A couple quick notes in our last minute. First is that if you are attending this and you registered, you will receive a notification with slides via the email that you use to register. So whatever email you use to register for this is the email where you will receive slides. And they will be available in 5 business days. And also keep an eye out for CME information, also to the same email address, and you'll get an evaluation by June 3rd. If you don't receive it by June 3rd, then check your spam or your junk folder. Sometimes it goes to that. And then CME, once you complete that evaluation, will be available in 6 to 8 weeks. Thank you guys so much. It is exactly 1:15. And so in the spirit of everyone's time, I hope you guys all have a great day. And thanks for joining. Bye.
Thank you.